Thank you, Dan. I'm starting getting used, to you moderating my presentations these days. So these are my disclosures here. And Liz, thank you so much. I could not ask for a better introduction, to my talk. I think that you just set the stage there, for a great discussion. Now, we talked about, that should not be plain, but we talked about the challenges of the hostile neck. And we're listing their specific characteristics, but the fact of the matter is the majority of the time, these characteristics are, how do I get back on this? No. These characteristics are not isolated. You usually don't just have a short neck. You usually don't just have a wide neck. There's a combination of things. And the fact is that we're treating more and more patients that are older, that are compromised in terms of their general health status, and endovascular repair, if you're going to want to treat them, is kind of a one-way street. So how do we handle that short neck challenge? The problem with these suboptimal anatomies is that you develop micro leaks at the proximal seal zone, and over time you're losing your proximal seal, and you're having those type 1A endoleaks that are threatening the aneurysm in terms of rupture. The definition of the short neck is any neck between 4 and 10 millimeters. This is definitely outside the IFU for the majority of the endografts. I think that there's only one endograft that claims a 7 millimeter in their IFU. But the short neck is associated with higher all-cause mortality, a higher rate of immediate and remote type 1A endoleaks, and also a higher rate of proximal seal zone reintervention. So let's keep those things in mind, and that's going to come on assessing some of the data that is out there right now in terms of the different solutions. So if you look at this meta-analysis, it points out exactly to that. And I put it up only to put some numbers there and correlate them with some of the outcomes that we're going to be discussing. Early type 1A endoleaks within the first month, 6.5%, 7.1% late type 1A endoleaks, about 15.5% of patients require intraoperative adjuncts, and about 1.5% of patients are experiencing stent graft migration. Now, as you're looking at EVAR outcomes, just plain EVAR outcomes, the long-term data come from a time where we were using totally different devices, totally different technology, and technology has evolved, and the plain EVAR outcomes have become better over time. I belong in the generation that we lived the evolution of the different devices, and we knew exactly the limitations and the advantages of the new device, and that plays its role here. So what do you do when you're having a short neck anatomy? These are your choices. You can do open repair, you can do fenestrated repair, you can do a standard EVAR by reinforcing the proximal seal zone with endo anchors, or you can do outside of IFUs chimneys. That is particularly a solution for the very acute patient presentations where no other solution is available. So let's go and take care and take a look at list on some of them. Fenestrated repair. If you're looking at a fenestrated graft, the most common configuration in the US is either a scallop and 2 fenestrations for the scallop for the SMA and 2 fenestrations of the renals, or a bigger fenestration for the SMA and 2 smaller fenestration for the renals. This has been traditionally the one configuration that's been used the most. That presents certain construction limitations. So the anatomy needs to be such that a graft can actually be made to the patient-specific characteristics. So that's one of limitations if you're planning to do a fenestrated repair on a patient. If you have aneurysmal dilatation at the origin of the renals or aneurysmal renal arteries, that's another problem. If you have significant stenosis or aberrant anatomy, such as large enough accessory renal arteries, and I'll show an example on that, that's another limitation. If you have tortuosity in the pararenal aorta or diffuse iliofemoral disease, these devices are in general larger devices and require good size iliac arteries. And then there are certain limitations with old EVAR devices if you're trying to do a fenestrated revision of a repair. Endo anchors were introduced to practice about 12 years ago as a means to enhance proximal seal and fixation of standard endografts. So each screw is about 4.5 millimeters in length, and it's designed so that it penetrates the fabric of the endograft, but also the entire thickness of the aortic wall to engage the adventitia. And that's a very important part when you're talking about success in placing endo anchors. We talked about IFU. Let's compare those two things in terms of IFU. You need a neck length of 4 millimeters or longer for both of these techniques. Endo anchors allow you to use a standard EVAR when neck angulation is up to 60 degrees. A EVAR on IFU is less than 45 degrees. Again, we're pushing that envelope, and I'll show you another example of that. They're treating the same aortic neck diameters. They both need to have a morphology suitable for aneurysm repair. Otherwise, you should not be attempting endovascular repair. There is a little bit of a difference on the definition of what constitutes an aortic neck, but the majority of people think that an aortic neck is the length of the aorta below the renal arteries, where the diameter doesn't change by more than 10% the diameter of the aorta at the renal arteries. And that's what we're going to use for this. So let's see some of the EVAR-specific complications here. I talked about access site complications. These are like really larger devices, and sometimes you can cause significant damage in smaller size iliac arteries. You can also encounter problems with perfusion of the lower extremities, and we have devised techniques to avoid that in long cases. Failure to cannulate target vessels is specific to this particular repair. Endoleaks, particular type 1C, which is an endoleak that's coming from the distal end of the side stent, is also specific to this type of repair. Target vessel occlusion is something that is being talked but not talked enough, and some of the results clearly indicate that this may be an issue down the road, and there is indeed a small risk of spinal cord ischemia with this particular technique. So let's see here some of our cases. This is a very good anatomy, if you will. EVAR, you'll see that there is about 6-7 millimeters of neck below the lowest renal artery. The neck is straight. The renal arteries are pointing upwards. You can see the cannulation of the right renal artery first, the left renal artery, and then the repair. And you can balloon, and you can extend your seal zone all the way up to the level of the superior mesenteric artery. In this particular case, the superior mesenteric artery was stented with a very good result. This is not my case, but I did borrow it from a publication. This is where the IFU is being pushed for a fenestrated repair. Here you can see that you have a significant angulation right below the renal arteries. The cannulation of the renal arteries did occur despite the challenge, but the patient ended up with a type 1A endoleak that then required extending the proximal seal zone and doing snorkels on the side branches of the renal. Clearly not an optimal result. I tried to put together some of the published results that have a little bit of longer-term follow-up. I did not put the ORDERIT study because that's definitely like the gold standard to what everybody compares this thing with. But there are some people in these studies that have extensive experience, like with fenestrated repair. So let's look at technical success. Technical success for EVAR means you're able to deliver the graft, you're able to cannulate the designed vessels and deliver the side branches. So technical success ranges between 90 and 97%. So why is that variability so significant? Because the different groups represent experiences in different stages. So the study from Svensson from Denmark represents their early experience, and you can see that the results there are suboptimal. Why is that important? Because the outcomes on an expert's hands is not necessarily the outcomes that you see on everyday life. Perioperative complications defined as renal, pulmonary, cardiac, access site, or spinal cord ischemia are in the range of 11 to 12%. The rate of reinterventions, and this is rate in the first 3 years, again, ranges between 10 and 40%. The 3-year survival, and this is all-cause survival, is fairly good on this patient population. But then perhaps the most important complication that needs to be taken into consideration is the target vessel occlusion. And here there's also significant variability, anywhere between 2 and 10%. And that in the different studies has to do also with the definition. In the study from Katsagiris on JVS, this is primary and secondary patency. This one is primary patency only. So there is a number of vessels that occlude, but then you have the option of reintervening at the end. So the transmural fixation of an endograft with endoanchors has some unique benefits. It does establish the strength of a sutured anastomosis, and that's been demonstrated in an in vitro environment. It does protect the proximal seal zone, and it does protect and promote sac regression. The endurance stent graft got approval to be used with in combination with endoanchors for anatomies that are 4 millimeters or longer in the proximal neck, and it was based on this series. They looked at patients from the anchor registry, and they found that the freedom from all-cause mortality was 93% the first year, 87% on the second year, similar again to what we were seeing with fever at the 3-year mark. The freedom from aneurysm-related mortality was 94%. The freedom from secondary endovascular interventions was 95.5%. So we're talking about 4.5% secondary interventions. And freedom from rupture was 100%. Now, the aneurysm-related mortality is interesting to see here because these were 3 patients that died of cardiac arrest at days 5 to 9, and then 1 person that died from alcoholic hepatitis within the 30-day window. The secondary endovascular procedures involved 1 patient. This patient had an endograft that was deployed without covering the entire length of the aortic neck and ended up requiring proximal extension and sac embolization. And I'll show you a couple of cases where I believe endoanchors can be very helpful. This patient came in with rupture, was hypotensive, female patient. We ended up treating her with endovascular repair, and we reinforced that proximal seal zone with endoanchors. If you look at the final angiogram, it's without any type of an endoleak. And I'm showing the follow-up CTs here with a decrease in sac size at 4 months. No evidence of endoleak on duplex ultrasound at 7 months, and then in 1 year, sac regression to 42 millimeters from an aneurysm that ruptured at 7 centimeters diameter. And this is an anatomy where a fenestrated repair would not be feasible. This patient had a good size accessory renal artery, but the main renal arteries were 4 millimeters diameter each, not the best for fenestrated repair. We ended up embolizing the accessory renal, putting an endograft in a 7 millimeter neck below the renal arteries and enhancing this with endoanchors. And this is the 1 year postoperative follow-up for this patient. We have an experience now that has reached 40 patients. This is from a presentation that we did to SCVS a couple of years ago on 25 patients that had hostile neck anatomy. And what we showed is that even at the longest follow-up, the majority of the patients had exhibited sac regression or sac stability, with only 3 patients exhibiting sac growth, and those were patients that had type 2 endoleaks that required coil embolization. So if you want to compare these procedures, EVAR does maximize the length of the proximal seal zone, and that's an important component to consider in terms of durability. It's something that in a good anatomy and in a younger patient should be considered. It does have a custom-made design that addresses certain patient anatomic characteristics. And it does seal in the visceral segment of the aorta that is more resistant to proximal neck dilatation. The disadvantages are that it's a larger size device, it's technically more demanding, it requires build time, it usually takes 3 to 4 weeks before you get the device to utilize. And there is a number of side branch complications, spinal cord ischemia, revisions are much more challenging, and there are anatomic restrictions to it. Endo anchors offer the ability to be utilized off the shelf, they're less technically demanding, smaller size, and they don't preclude future extension of the proximal seal zone. That's an important thing. You're not burning any bridges by using it. However, the short seal zone requires very accurate endograft deployment, and that's a main determinant of success. And full thickness aortic wall engagement by the endo anchors is another determinant. So technical considerations are very important in here. The limitations in certain anatomies include extensive aortic wall calcification and thrombus, which prohibit the accurate deployment or the full thickness deployment of the endo anchors. So there is room for both. The patient selection is the most important component here. You need to understand the limitations of every device, and you need to understand the advantages of each device. But there is room for use for both of these techniques in different environments, and there is an ongoing study now that is set to start in Europe in order to evaluate and compare the safety and performance of endo anchors and fenestrated repair for the treatment of patients with short neck anatomy. Thank you.